Good afternoon, everyone. What we're going to discuss today is the concept of integration of behavioral health, mental health services within the primary care office, specifically from my perspective is pediatrics, but certainly I think a lot of this can also relate to those in family practice. I think what we're going to go through is looking at the benefits both to your patients, to the community, and you as providers. Having spoken to pediatricians over many, many years since I started doing this, there's certainly a concern, fear amongst providers of delving into the concept of managing mental health, behavioral health. And although it can be challenging, and we're going to talk about some various different ways of getting better trained and experienced, it just takes time. And it's like everything that we do as physicians is that it's something we need to learn, we need to develop confidence and expertise. And over time, you will do this, whether it's asthma and the changing ways that we manage asthma or any other type of medical issue. First and foremost, my perspective certainly goes along with a lot of the character that is my most favorite characterization from Williams, and that is Patch Adams. And again, I think just in general, we all need to know, and I think most pediatricians by nature, maybe we're not all clowns, but we certainly are usually very jovial, happy, and our role as a doctor, our role as a pediatrician is always to be there for our patients, but to be the one that is able to guide and lead them and not put the onus on them, not to make it their responsibility, but we need to take that off. And sometimes, yes, it's a little bit of a risk, but we're doing the right thing. And I always have believed that we can help our patients, make them happy, make them successful, if we always know and keep in mind that we're doing the right thing for the right reasons. There's a lot of epidemiological facts here. I think the key fact off of this slide is the fact that mental health is becoming more and more prevalent in our practice from day to day. The first bullet point there, I think, is probably one of the most critical bullet points, and that is that 1 out of 5 children and adolescents meet the criteria of mental health or substance abuse, but only a fifth, 20% of them, ever receive treatment. And that is something that we need to try to change and correct as forward. Most of you, I think anybody here probably on this webinar will recognize that as pediatricians, we are now identifying and managing and dealing with more and more children with emotional and behavioral disorders. The reasons behind this, probably we don't totally understand, are multitude, and probably could be another entire hour of discussion. But certainly the fact is that's who is showing up in our offices, and we need to be better prepared to manage and take care of them. Again, and we're going to get into what we have done in our particular practice, but I think it's extremely important to recognize that a couple of facts that you'll see here and that is that we need to develop close relationships with those in the field of psychology and behavioral health and therapists. And one of the benefits, as you'll see as we move forward in this presentation, is that we need to be able, if we're going to manage behavioral health, we need to be able to communicate well with the psychologist, the therapist. And without having a psychologist nearby, close, that becomes very difficult. And I think that one of the previous slides, one of the things that were noted is that majority of physicians have difficulty, maybe close to 75%, have difficulty finding a psychologist, finding a psychiatrist, finding the right therapist for our children. And so, and it's very frustrating, time consuming. So having that psychologist close by, whether it's within the office, within the building, within the close neighborhood, I think becomes important. It enables us to communicate closely with that psychologist. And as you all know, probably have had the experience, it's, you know, the notes that we receive back, whether it's from psychiatry or psychology, are very limited and scant, and trying to connect often with a psychologist because they're busy in their hours, and unlike us that we can sometimes catch phone calls between patients, they're committed to their clients for that entire hour. And the only other thing here is that, and again, I'm not sure how much this is pediatrics in general versus family practice, but most psychotropic prescriptions are already being written by primary care physicians. The public health concept here is, and yes, this is a public health issue for us, and we need to address it as such. Understand that mental disorders, behavioral disorders are associated with increased physical problems. We spend a lot of money, time, unnecessary worry, we make them go do all kinds of exams, whether it's MRIs, upper GIs, colonoscopies, because the child presents with a physical condition such as abdominal pain, when simply with good questioning, with the right history, we can determine that more of this might have been along the lines of an anxiety disorder, for instance. So I think that's important for us to note. And again, I think we'll recognize that if we get more engaged, more involved, not only are we going to provide for better outcomes, but we're also going to provide for efficient care at lower cost. And the other thing that we need to recognize that this slide points out from the standpoint of just the general population health is that we need to be able to treat children with even minor issues. We all know that if someone is, presents with suicidal ideation, or they come in with hallucinations, certainly the system is triggered and we get those kids into care. But it's not just those children with severe mental disorders, but we also need to be able to treat those with minor, and minor is in quotes certainly, but certainly it does have an effect on the child's physical health outcome. Again, this slide, I think, speaks to some of the issues I just talked about. Again, recognizing that mental disorders are very commonly either underdiagnosed, and sometimes that's for fear that the physician, nurse practitioner, healthcare provider is afraid to ask the question, afraid to do the screening, because then what do you do with those results? Who do you refer that patient to? How do you manage that patient? So when that happens, certainly if it's underdiagnosed or diagnosed late, we're delaying treatment. And often treatment is started early, certainly avoids issues later on. So, when we have a child, for instance, who presents with ADHD, but doesn't start getting treatment until they're 15, 16 years of age, we all know that it's just going to increase the likelihood of having problems with oppositional behavior, school behaviors, and eventually self-esteem, because that child knows that he or she can do better and perform better, but constantly they're not able to meet their own expectations. And when that happens, that leads to not only more frustration, more oppositional behavior, and eventually can lead to poor self-esteem. And with that self-esteem being lowered, that's hard to turn around, even if, in their adolescent years, we start treating the ADHD. So again, I think the slide is just trying to point out clearly what are the benefits of us as physicians managing and treating patients within our offices. Certainly, patients have a greater comfort being in our office. They have confidence in you as their physician, as their pediatrician over many years. They recognize, and you need to constantly emphasize, that you are that trusted source of support, because there is so much stigmata when it comes to mental health. Parents tell me all the time that they're much happier that they're bringing their child into my office for therapy, much happier that they're coming to see me to be able to talk about their child's behavioral health issues, school issues, as opposed, and many of these have already seen psychiatry. And again, there's some great psychiatrists. I'm not, in any way trying to minimize that, but the biggest issue also is the fact is there are so few child psychiatrists here in the state of Florida. I think the number is somewhere around 350, which is not many to cover a state as large as ours. And so, but even with that, they have a comfort level of being in the pediatric office. No one knows why they're here. Okay, again, going back to the whole confidentiality issue, I think that's important. Obviously, it's usually more convenient. When I tell you there's so few psychiatrists in the state of Florida, obviously they're going to have to travel somewhere to be able to get to that psychiatrist. Is that holistic approach. We know the patient best. We've known that patient since he or she was a small infant, a toddler. We've gone through, and we probably have known their siblings. So we know them well. So we know other issues. And when we talk about holistic approach, it's not only looking at their physical well-being, not in their mental health, but looking at the social issues, the social determinants of health. That becomes important. And as pediatricians in the patient-centered medical home, we're much more open, and I think we can approach them better. Same thing, being much more family focused, and certainly that seamless care of trying to accomplish everything within the office. So that's, this is just a slide here that just really talks about all the different diagnoses that we manage at Pediatric Partners. The number one diagnosis that pediatricians will see in their office is ADHD. I think most pediatricians are comfortable with straightforward ADHD, But always remember, 60% of children with ADHD have comorbidities. So we have to understand those other comorbidities and be able to deal with it. Second is anxiety disorders, and then depression. And so those are definitely the top three that we see here in this office. But we also do manage some of the other disorders mentioned on this slide, including disruptive mood dysregulation disorder, which is in DSM-5, the new diagnosis for mood disorders, sort of a, instead of using the term bipolar in children, but not necessarily do children that are diagnosed with DMDD go on to having bipolar. But it's a comfort level that you start learning, and and as you start talking to patients, you start understanding much better the need. Unfortunately, a number of children, both boys and girls, with eating disorders, something that we always have to be very sensitive to, often presenting late. Certainly dealing, and we're going to have some more time to discuss it later, children on this autistic spectrum, dealing a lot with parenting issues, behavioral issues, some substance abuse, but as everybody, I mean, I think every pediatrician is dealing with some substance abuse. The number of adolescents that are smoking Juuls, the number of adolescents that are using frequent use of marijuana. So it interfaces with just our everyday care, and it's something just being aware of, being able to have those conversations with the children. Something that we will probably talk, I am going to talk a little bit more later, but it really sort of interfaces everything you do within for an earache, or they're coming in with severe abdominal pain, is that being aware of trauma. I'm going, a huge number of children and adolescents have been affected by trauma. And when we talk about trauma, I'm talking about ACEs, adverse childhood experiences. And we have to keep that in mind, because often fidgetiness, lack of or increased distractibility may not have ADHD, but may have, abusive situations or traumatic situations in the past. So we always need to be alert and aware that something else may be at play here. Again, I know physicians often, as I said before, don't feel comfortable, and we're going to talk about where you can learn and where we can learn more. But it's just your commitment and dedication to doing it. And you're going to learn through your patients. It's constantly getting feedback from your patients, but you can do it. I like to refer, again, this will show my age, but certainly when I was practicing here in the late 1980s and serving on one of the hospital's medical executive boards, I remember many discussions we were having at that time, because laparoscopic surgery was relatively new in the mid to late 1980s, which is hard to believe today. When you look back, you think that the surgeons, who certainly were not had never received any training, none whatsoever, during the just do a weekend CME course. And yes, it was maybe a 48, 72-hour course on laparoscopic surgery. And then just after a 2 or 3 day course, they expected the hospital to credential them to be able to, start performing laparoscopic surgery. And when there's a new procedure that's never really been done, there's not certainly a lot of experience to look at it, neither for the physician nor the hospital. And yet, it always amazed me that just within a couple of days, they were able to be sort of signed off on being able to perform laparoscopic surgery. And the feedback that I get from a lot of physicians is, but we were never trained in psychotropic medication. We were never trained in mental health. We were never trained in behavioral health. And yes, there's some of that training going on now, but way too little of it in residency programs. But my response and my feeling at that time, and still is today, is if surgeons can, and maybe because I'm not a surgeon, and maybe, I don't totally can relate to this, but if they can go back in a 2 day course, learn how to do a whole new concept type of technique of laparoscopic surgery, we can learn a different medication. Medications are medications. There's always new medications in the field, whether again for asthma, for cardiac problems, whatever, for rheumatology, and certainly that's a field in which it's growing very rapidly. So as physicians, we are obligated to continue our education and start learning about new procedures and new, medications. So this is the beginning of where we want to spend most of our time with talking about what we have done in our practice. At least that was what I sort of looks at, how our office is set up, because although a few of us are behavioral health, not every physician is, but every member of my staff and every physician and every nurse practitioner has had some training, has had some insight, and are part of the overall team. And it's important, and I'm going to walk through an example of a patient with you in just a moment, but just to quickly review what's there on that slide. Certainly phone calls come in, parents, because the child's been kicked out of daycare for the 5th time. They've been suspended for the 5th time from elementary school. God forbid they've been Baker acted, and we're going to talk about that in a little bit later. There comes that crisis call. It comes through either our triage nurses or our clinical coordinator. They make an assessment, talk to the parent, make sure to see whether or not this case is emergent, something that's been going on for 10 years, something that needs to be seen 24, 48 hours. But typically we get all new patients with issues into our office within 1 to 2 weeks. Certainly same day appointments if there is a crisis. Our front desk is trained, our medical assistants are trained. We have trained them in the past via CARD, which is the Center for Autism and Related Disorders. There are multiple CARD centers throughout the state of Florida. There are children with sensory issues, with children who are on the spectrum. But it's not just those children, but it's any child who comes in with any kind of issue, anxiety or so forth. We recently had a child who was coming in just for a simple, a simple cold ear infection, 14-year-old. He presented himself, mother checked in, sitting in the waiting room, waiting, and the child started having a panic attack. What was amazing was that my front desk recognized what was going on, reached out to our medical assistants who brought the child back into our sensory room where Paola, who's one of our clinical coordinators for this program, came in. She wasn't actually seeing patients at that time, but came in, started working with Miguel with lights and with smells and other things, and with weighted blankets that we have in our sensory room. And Miguel started calming down enough that Dr. Samuel, one of our physicians, was able to come in and say, no, this is not because you think you're going to die that you're going to die, but you have a cold. And then we were able to then start dealing with the issues of the underlying anxiety. But the child now comes into this office without fear. You're going to see one of his photos. I happened just to see him this morning, and he says, Dr. Schechtman, I'm going to be famous because I'm going to be on your talk. And so he's that transformation, that understanding of dealing with these patients makes our lives as pediatricians easier when they're coming in for vomiting and diarrhea, for cough, whatever have you. So it is that holistic approach that becomes important. Some of my pediatricians that are in our practice are seeing children for consults and med checks, sort of our own internal sort of training session with workshops, but even more education on specifics of medication, the different medications, as well as our approach and how to handle different situations. And that's been very successful because, as you'll see also a little bit later, the number of patients that we're seeing that are presenting with behavioral health issues is rapidly increasing. And again, we have an embedded psychologist, Dr. Anderson, who again, in the case of Miguel, we were able, all within the same office, was able to set up an appointment to see the child the following day. We also have a social worker, Ruthie, who is quite amazing in how she manages the patients and deals with the families. It has taken a tremendous load off of my shoulders, the fact that she's there, being able to provide community resources, being able to help parents. We've homeless and destitute, and she was able to meet them at the public library, trying to get them support. So there's many things that we do, again, going back to the concept of social determinants, that really impact the health of our patients. Certainly we have case management and care coordination going on all the time, trying to make sure that the children and the families receive the care that they need, the therapies that they need, which are sometimes difficult to get. This is just an array of the various services that we have in our office. Again, I think that it's just the most important message here is the awareness of an entire staff, because it does take an entire office to be able to manage patients with special needs, with behavioral issues and any type of issues. we do developmental assessments here. We use a program called Chattis, which is, some of you know, it was developed by Barbara Howard, who's an amazing woman and does amazing things when it comes. If you ever have a chance to listen to her speak, she's great on any topic. But Chattis enables us to screen not only parents on developmental issues, but on psychological issues, be able to reach out online to teachers, also allowing teens to respond to questionnaires on their own. Again, some of the photos here in the upper right corner is the concept that you need to be at the child's eye level. You need to be on the floor. You need to be where it is to try to work with that child to understand. And again, whether it's a toddler, as in this picture, or an older child, I think it's important. In the lower right is our social worker, Ruthie, who is interfacing, with a mom who came in worried that her child had autism, and Ruthie's trying to help her go through something called Autism Navigator, which is an early screening tool that we use for to rule out autism. Her child did not have autism, but the fact is, it's again that interaction, that because moms come in, as you all know, frightened and scared, and it's hard for them to be able to give a good history sometimes, and this helps facilitate some of those patient issues. Again, just a quick picture in the upper right, that happens to be Miguel, but this is our sensory room, and again, it affords us the opportunity. And I also have to tell you that most parents, whether or not they're truly neurotypical, but they love the sensory room too, and it's hard to get them out of that beanbag. The next thing is that our approach to children with sensory issues, and especially when it comes to procedures, as you all know, it can become very difficult to get a child who may be on the spectrum, has other processing issues, to be able to do just the simple things we need to do in our office, such as taking vital signs. We have developed a series of visual cues, cards, that helps explain to them what that procedure is going to be like. And over a period of time, it works. I mean, first visit, no, it takes multiple visits for that child to get comfortable with it. Something else that we as pediatricians do a lot, and that is interface with our schools. There's a lot we can talk about here, and especially becoming that advocate and that support for schools. The schools are desperate for medical information and support. They need to talk to someone, because again, it's very difficult for them to manage, sometimes all the issues they're seeing, and they're like a sponge that soak up information. Again, we need to do 504 plans, IEPs. Again, that just really simple. 504 is a federal law that states that children should receive accommodations in order to be able to receive an appropriate education. Excuse me. And then individual education plans is actually providing accommodations to ensure that children receive the education that they're entitled to. Hospital homebound programs. Again, I work with the Palm Beach County School District, interfacing with a lot of physicians, and it's just one of the many areas in which sometimes, there's no question that parents come in and demand something. Psychiatrists, neurologists, pediatricians, anybody just signs off on a program. So just to help, to give the parent what they want. And again, we need to be accommodating to parents, but we also need to be able to get the right care. And you got to be very careful and recognize that what hospital homebound programs were to begin with was back in the day when children were in hospitals for many, many weeks for things that today they're in the hospital for less than 48 hours, if that. And so it is not meant to keep the child out of school. We need, especially children with anxiety, depression, they need to be in school. So there needs to make sure that anytime you write a hospital homebound program, that there is a plan for transition, re-entry plan. Again, we can talk more about that if people have questions, but it becomes really critical from that standpoint. Another thing is again, for those that are seeing children and you're prescribing psychotropic medication, it's important to have some form of medication management agreement. I think it becomes, as we know that most of our children with ADHD, it's very often they call up and say, oh my goodness, we're out of meds and he has a big test tomorrow. And then everybody goes crazy. You need to rules just like you do with your own children at home. You need to have guidelines they need to understand, and so you can start correcting that behavior. Otherwise, you can certainly go crazy yourself with all these demands and trying to accommodate. Team approach, we can never get this done without everybody working and talking together, I think it becomes important. And as I was saying before, the opportunity to a social worker or other physicians and just grab them in the hallways becomes immensely helpful in us being able to work through this. This is just another demonstration of a child, again, a young child. I think she's probably 4, maybe 5. And, you know, again, children, again, she does not have any diagnosable, you know, mental health, behavioral health issue, but she is only 4. So again, she need, you know, that fear factor at 4 is great sometimes, especially walking into a doctor's office. Getting them prepared for a visit becomes very important. Again, we're working with children and their feelings. We need to get that to make sure they feel comfortable, different things that we can work with it. One of the things that I always talk to, especially with my older patients, is for them to understand, because often, you know, in our interview techniques, and again, we all need to get good with that and better with it and how we approach, and we need to be empathetic, not coming across critical, but we also need to get to understand what the real issues are. But if you tell the patient that certainly there are no right or wrong answers as you're talking to them, that this is not a test, but that their feelings are their feelings. And it doesn't matter, I mean, it's important to know what mom or dad or teachers, they're only really important about how they feel, and to reassure them that no one else can tell them how they feel, only they. And again, I think recognizing that becomes really important for how we manage kids. Again, you all know this is basic, but I think it becomes, we lose sight of this sometimes, or, you know, we get numbed. But really building that relationship with your patients and family becomes important. How this becomes something for us, photograph to the left, is a family in which this mom, who tried to get pregnant for many, many years but unsuccessful, adopted these 2 beautiful boys from Uganda. She came to us because I believe that she was concerned that one of the children was having lots of, I think it was an occupational therapist at the time, or physical therapist was saying, you know, her child has autism, and she came in here in tears. Make a long story short, you can see her happiness and just her smiles. And we've worked with these 2 boys, and yes, there was a lot of neglect. There was absolutely a lot of neglect, and you know, being in orphanages and never having that sort of loving family before they came here. And since they've been in her home, they have received that love, and they've made great progress. The other thing they have received, which was amazing as soon as she got home, they now have a brand new baby sister. So after she couldn't get pregnant for years, she came home with these 2 boys, and she became pregnant. So that's all great news. But the point also I want to make here is that these boys were seeing another pediatrician. They were not being vaccinated. Mom's choice. Through our work with the whole behavioral health, she eventually moved those children, now all 3 of them, again, 3 new patients, which is, you know, again, from the standpoint of what we do here, and, you know, as a business, and we're all in business, you know, we have to succeed in being able to keep our doors open. She has moved those children to us, but also the boys are now totally caught up with their vaccinations and, you know, thriving. Just quickly, the child on the other side was a child who is 9 years old, who is on the spectrum, and who initially, when coming here, was never, you could never come close to him, touch him. Became very irritable, hid in a corner, but through, again, a lot of work, it doesn't happen overnight, this child, as you can see here, is easily allowing me to examine him. Again, another something that we can do when we provide both the medical care and the behavioral health care. An important factor that I think that I had not mentioned before, that I think is extremely what makes you special and unique as a practice, is that, and patients love the fact that even if they're coming in here for a med check, you know, just to, you know, for medication management, if they walk into the office and they come see me, you know, to have a reader, Focalin XR, but the child now has an earache, we're going to not make them go someplace else. We're going to that ear, manage it and treat it right then and there. We're able to also, because of the awareness of of all my practitioners, all my physicians, is that when they're seeing these kids for routine physicals, they're much more alert and aware of picking up some of the psychosocial issues that need to be managed, and then referring it internally and to help manage those patients. the fact is that I'm just going to quickly go through some of the things that we talk about. It's things that we commonly see. Certainly the most common certainly is the child with ADHD. Again, you all know that a child with ADHD can create a lot of challenges, and that's the word I like to use, to the family, to the household. And because of that, it's important for early intervention, important to make sure that these patients receive the care that they need. Anxiety and depression, again, a lot of my colleagues are concerned about it, but really, if you break it down, I like to call it the 4 legs to a stool, and our treatment plan, and we look at it. So the first thing you hit the parent with is not medications, but you talk about them having to improve their health, their lifestyles. Again, sleep, problems with, exercise, eating properly, self-regulatory techniques. They need to be able to, do mindfulness, breathing, walks on the beach, whatever it takes to relax them. Certainly therapy, and then certainly then we deal with medications. Again, the concept here is that we do have that embedded psychologist in the office, and I think that's extremely important to make sure we give that comprehensive care. Just quickly, certainly there is support for when you're prescribing psychotropic medications. University of South Florida has an incredible series of books that are developed by an expert panel on the management of psychotropic medications, listing every medication, going through their benefits and side effects, and it becomes important. Another thing that several of my physicians have been trained with, and it's a great program, is called the REACH Institute. If anybody wants more information about that, you can certainly give them that. But I think it's about a 2 or 3 day course workshop in which intensive training on how to approach patients with anxiety, mood disorders, ADHD, and so forth. Again, we've talked about the approach to autism. I think we've covered most of this, but again, it's that multi-service integrated approach to make sure the patient is getting everything he or she needs. I think the most important thing is being able to provide the parenting advice and support. This can be at times a very devastating and very worrisome diagnosis for parents. Often parents then go off in all kinds of tangents and looking for things, and you need to be that rock, that support to guide them to evidence-based care and treatment. And we need to be dealing with this, as we all know that the number of children being diagnosed on the spectrum is becoming a bigger piece of our practice. Telepsychiatry, this is something I do a little bit of with some of my college students, but what this was really meant for, and this was out of the University of South Florida, it's certainly more for being able to have patients connect directly with psychiatrists. Certainly there's a lot of benefit to this. Gives the ability for brief, visits for, that may be amenable to that type of things. It can improve outcome very quickly. Certainly it breaks down the hurdles. You don't have issues with transportation. And again, with the number of psychiatrists in this state being so limited, this is one way that I think there are different groups that are trying to develop more and more telepsychiatry. I do a little bit of it. Especially with my college. 2 quick examples is the fact that it's a child who started having a panic attack in the office because she was going off to school and she was petrified who was going to now manage her anxiety disorder. As soon as we assured her that we would continue doing that, we see her like at least 3 times a year in the office over Christmas, summer, spring break, and then every 2 or 3 months via telehealth, via FaceTime, or via other services that we use. She became relaxed. The other thing I find very, is always hard, especially with adolescents, young adults, are they truly suicidal? Are they truly having thoughts of self-harm? And when you have a child tell you that he's depressed, and yet you're in his apartment via the camera, you're seeing his friends fooling around in the background, eating pizza, he's eating pizza. It gives you a little bit of sense of comfort, not 100% reassurance, but certainly it does provide a lot more than if you're just talking to them on the phone. The other thing that University of South Florida is great at and has available for everybody is the pediatric psychiatry hotline. If you have questions, concerns about patients you're treating, this is specifically just for medication issues. It's a great resource for everybody. Let's see. Again, I think that this is a real important concept for everybody. Not only this is the whole aspect of including incorporating behavioral health, helpful for patient satisfaction, but physician satisfaction. For me, I find, after 30 plus years, there needs to be something more than snotty noses. Snotty noses are important, but there has to be something else that can be intellectually challenging, fulfilling, rewarding. And I think there's no question the field of mental health has done that for me, and I think it's an opportunity for everybody else. I think, as people know, when it comes to the business model, the future of pediatrics is looking different with all the issues of urgent cares, being able to manage snotty noses, physicals. We as physicians, as pediatricians, need to be an expert in something that we can be able to do. Again, NCQA, for those that are not aware of NCQA, is the national organization that deals with managing the quality and outcomes, and is who confers onto practices that may be patient-centered medical homes. They have just created a brand new distinction for behavioral health integration for those with patient-centered. Enables you to stand out to the payers, your partners, to your patients, to show and demonstrate that you're doing something different and special. Gives you an opportunity perhaps to contract differently with them. Again, so that you're going to give enhanced level of care and access is what this distinction states. And that you're giving comprehensive care. I think the important message here is even NCQA has talked about the fact that behavioral health is that important to them, and again that they have developed this, and this has only been in the last few months. Here's a slide that again looks at our practice and says, for the past 5 years, what percentage of our total patient volume, again, we have a general pediatric volume, pediatric practice in multiple offices, what percentage is related to behavioral health? And you can see in 2013, it was at 8%, and now it's over close to 14.5%. So again, the field of healthcare is changing. It's changing in many, many different ways, not just in behavioral health, but it continues to progress and morph. And we as pediatricians, I think to survive as pediatricians, need to morph with it. We're engaged in multiple research opportunities, some directly with the AAP. I mentioned Autism Navigator. We're doing something with Chapman Hill, which is part of Chicago, University of Chicago, that is dealing with development screening and how can they mitigate toxic stress. And a lot of this, again, you ask, how do you have time as a physician? Well, that's part of what my team does. Dr. Anderson, Ruthie Punkelman, and others, Dr. Conley, who's one of my pediatricians, very engaged with some of these programs. So everybody's sort of doing a part of it, and again, get involved. So I think that's important. Again, we spend another whole hour on the trauma-informed practice. I think what the important message here is to recognize this, to always be constantly looking at the fact that every patient that walks in, for whatever reason, may have suffered from some trauma, and to take note of that. I think most people probably on this webinar are familiar with ACEs, and the triangle there just again incorporates the concept that ACEs, adverse childhood experiences that children experience when they're young, will carry forward until their adulthood, and does increase morbidity, mortality. A sad factor, 37 out of 100 children living in Florida under age 5 have at least had one ACE. Again, something that means that 1 out of 5 patients that you're seeing in your office that are walking in have suffered from an ACE. Again, bringing it back to Florida, over half of children's infants and toddlers in Florida grow up in poverty. Poverty is, no question, the strongest predictor and influence on how children learn in school, their health, and I think it's something that we recognize that children that are raised are much worse than their peers in every indicator. So again, not that we can change poverty. I mean, people have been trying that for many years, and I think we need to keep trying, but I'm no way that we're going to fix that. But we need to recognize it, be cognizant of it, so that we can understand sometimes what's going on with our patients better. This is also, I think, a sad commentary on Florida, but this is true throughout the country, so not just Florida. But again, we all recognize as pediatricians, early intervention is extremely important. But in Florida, less than a quarter of children receive developmental screening, and only 2% receive early intervention. So again, it's places that are not very expensive, but that we need to work on. Just another graphic quickly showing, what happens in childhood impacts us definitely as we grow into adults. So we as pediatricians have the onus of accountability and responsibility to help guide our families along these lines. Again, asking questions is always hard. I mean, there's an NIH study recently stated that physicians, pediatricians, family practitioners are afraid to talk about trauma because, again, they're not informed. They don't have that education. They don't know what to deal with the effects. The study showed that if there was intervention with CMEs on trauma-informed practice, that they started doing better. So again, realize it, recognize it. Always recognize that what we need to do is ask about trauma in any visit, not just because they're coming in for psychological reasons. It's important to ask about these questions. It just should be part of your routine history. Let's not forget our moms. Our moms are caregivers. It's not always the child, but certainly maternal mental health is a big issue that we need to deal with. I sit on a statewide committee that's looking at maternal mental health. We just received we were one of, I think, 7 or 8 states that just received a big federal grant. So I think a lot more attention is going to come to it, but we as pediatricians are dealing with our moms all the time, so that becomes important. Something that's near and dear to me, and we're forming a new state committee looking at state health school health in the state. There is an alarming increase of number of children that are being Baker Acted, a number of children that are being suspended from school. Last 5 years, basically, I think it was probably 2010 to 2015 is where the data is that there is an increase of 49% of children being Baker Acted. For those that don't know what Baker Act is, it's just the term used here in Florida for involuntary hospitalization for anybody who is thought to be at harm for himself or harm to others. School suspensions are out of control. You all know as pediatricians, you're seeing more and more of that. We need to be very careful and cognizant of who and why we Baker Act somebody. We need to understand the child underneath that's in handcuffs has autism and essentially was Baker Act straight out of school. And even though he was in a program designed for children with autism, he was still Baker Acted. You can see he's walking in calmly, but it is an incredible situation in which it's horrifying because mental health hospital is reminding a child with sensory issues or autism. You can see the scratches, that's all from where they put him. We were fortunate enough to get him. I was able to avoid that hospitalization with talking with the psychiatrist. But again, we need to be careful. We can't just, again, people think, schools think, parents think, community thinks that Baker Act is the solution and resolution, and it is not. It is not, for any reason, not just for children, but children who may be depressed or because most of these children are just crying for help. But putting them into a hospital facility for 72 hours does not fix or cure them. They all have issues. They all have problems that we need to deal with. But we need to think carefully where and how we manage those patients. And finally, this is a sign of success, and I wish I could ask everybody if anybody knows what that is before. This is one of my teenage patients that came in with this tattoo, brand new tattoo, and I said to her, "What does this represent?" And she said, "It represents something that's changed my life." And I said, "What? Cannabis?" And I don't remember my biochemistry, so anyway, those out there who know it well, forgive me. But anyway, no, she said it was the sertraline, and that is the chemical symbol for sertraline, Zoloft, that you prescribed for me 5 months ago. It's changed my life. So I'm thankful she tattooed a chemical symbol and not Dr. Tommy, but the fact is, it is something that you can feel good about and change people's lives. Okay, so with that, I'm going to stop and I guess turn it back to you, Ron, to see if there's any questions.
Okay, I've only seen one question come in so far, and it says, will coding or reimbursement be discussed given so many other services may be needed as well as visits are time consuming? So
again, the nature of this talk, I think, again, that could be another whole talk. I touched briefly on the business side of it. I think that when you basically are billing for behavioral health services, you need to do it by time. And again, you look at how much time you spend with the patient or family, and that will be the determinant, for your E&M code. I don't use counseling codes specifically because, again, you have to have technically a referral from somebody. Those are much more difficult to get paid for, but I've been very successful with just using 99213s, 9921405. So, and basing most of it on time and on the time element.
I just got another question in here.
Okay, so there's an excellent question.
Were you able to read that?
Everybody sees it.
I was asking if you're able to see the question.
I have, yeah. So the question is basically is for those that are not patient-centered medical home, how do you start training? There are, some programs out there. Patient-centered medical home is just recognition from NCQA that you have achieved it, but it's really not an educational process, although there's education to it because you have to go through, it's telling you where you need to do things to look at outcomes and quality. I think for physicians, I think the REACH program, which I have no association to, I mean, I did take that course a few years ago, but not affiliated, so I'm not, but it is one of the few programs out there nationally that Dr. Jensen, who led some of the very early studies on ADHD, has created, and is a wonderful program of, like everything else, you just have to dive in, go slow, start low with medications, get good feedback, get feedback from parents. Again, with most of these medications, as you know, is that there's not like something that we can measure. It is feedback. So it's not like, as I explained to parents, it's not like a thyroid that you can measure a blood level and objectively know how well the child may be doing. So again, it's just feedback. And, the issue that you have to remember, if you don't do it, probably no one else is going to do it, because the access to care, access to mental health care is so limited for lots of reasons. And so I think you have to start dealing with it. I think the USF hotline is a great resource, and that's how you learn. I will tell you one of the things with REACH, I'll go back to that, is I think I think it's like 6 months after you do the program, they do, I think every other week, calls were for 6 months. I'm being corrected here, but anyway, that's good. And you do an hour call in which your colleagues that were in the workshop with you review. You get to present cases that you're seeing in your practice, and then get everybody to give feedback on how you're managing it. So I think is a great place to start. As far as trying to talk with staff, I think giving the approach, reaching out to your local card, I think they would also help you train some of your staff.
All right. Thank you, Dr. Schechtman, for your presentation. This does conclude our broadcast. Thank you very much, everybody, and have a great afternoon.